do like to talk about the learning pyramid, and the the 10% retention is when you just kind of listen. The 90% retention is when you actually participate. So, but nevertheless, it's valuable, and you can always go back and look at these slides and look at them, whenever you want to at your leisure. Um, I think a lot of these we try to choose things that are either they're going to be on the boards or they're kind of interesting things that'll have differential diagnoses that can be on the boards. And so, it's valuable when you're studying and getting ready for your boards, or also your, I guess they're these little tests you take kind of in their interim between the boards to make sure that you can go on from one year to the next, which is kind of interesting. But anyway, first we have the shave biopsy. And you all know we always start off and ask what kind of biopsy we're taking. It's interesting because this is an inflammatory process, but they probably thought it was a neoplasm. And, we see this actually fairly common. Somebody will have a little papule there, and maybe it's due to inflammation. That's not something you're taught in residency very frequently. You see somebody comes in with a little papule, maybe you'll take out your dermatoscope, you'll look at it and say, well, differential diagnosis might be a nevus or basal cell or something like that. And then you do a shave, and lo and behold, it's like a little ruptured folliculitis on the face. If somebody's got rosacea, or maybe it's a benign cyst or something like that it's not really a cancer, it's a ruptured follicle or cyst. So I was never really taught that you think about inflammatory things in the differential of neoplastic diseases really much when we were residents, but when you have the real world, you see that all the time. And we see tons of lesions that are sent in to rule out basal cells that are ruptured folliculitis or something else. So they probably sampled this by shave technique thinking it was a cancer. Probably was a little bit of an elevated papule, and did a little saucerization of it. It's on severely sun-damaged skin. It's not on the face. It's probably like maybe the, extremity, most likely, given this diagnosis. And you see there's something that's abnormal right here. And so when you're faced with something that looks like it clearly doesn't belong in the skin at all, then you're dealing with things like foreign material, possibly, or maybe infectious diseases. So you want to have you keep your mind sort of broad and think about different things that can do this. And here you see it's got this brown color to it. And if you look at higher magnification, it's got these little individual cells in here. So this is a foreign body, and it's a splinter. Now, I don't know what kind of splinter it is. It could be from a rose thorn, could just be a piece of wood. Maybe the patient was working out in the, tool shed or something like that and got a piece of wood in their hand, or maybe they were just, walking in the staircase or something, and the little splinter came off of the railing and got them. But this is a classic example of a splinter. It's pretty easy. So, you really wouldn't have too much difficulty making this diagnosis. Now, there's one interesting thing about this, though, that I want to call to your attention. If you look carefully over to the side of the splinters, here's the wood, okay, pretty straightforward here. But here you've got this brown material here that's got these little tiny holes, and if you look really carefully, these are hyphae right here. Dermatiaceous fungi that are present in the splinter, okay? And this is actually seen very commonly. Here you see it over here. It's a really nice example of it here in this area where it's not quite as dark. And so if you basically go out into the forest and take some soil and culture it, you're going to get all kinds of dermatiaceous fungal organisms that grow. Phylophora johnsellmi, Alisheria boydii, Cladosporium carrianii, things that cause things like tinea nigra, that cause things like chromoblastomycosis. So those organisms live in Mother Nature. And so here, this splinter was infected by the same kind of organisms that cause disease in you and me. This guy does not have chromoblastomycosis. He does not have pheohyphomycosis. He doesn't have a disease. His splinter has a disease, but he doesn't have the disease. So, and there's a dermatologist that friend of mine, he's moved from the DFW area now, but years ago he said, I've got this diagnosis of chromoblastomycosis, and he showed me the pathology, and he had a splinter that was infected with this, and they said he had the infection, and he didn't have the infection. So just realize that this is sort of a red herring. It does not mean that the person's got the disease if the fungal organisms are living in the splinter. This is just sitting, he doesn't have any real inflammation around this. The host, as you can see here, has formed a nice little wall around the organism, or well, around the splinter, and is trying to transepidermally eliminate it through the epidermis. It really hasn't happened yet, so it's formed a little cyst. So since it hadn't gotten it out of the body, it says, well, let's just form a protective barrier so that none of these organisms really could ever cause an infection, or it's just a foreign material. Let's get rid of it. They don't want to, your body don't want to have it in there. So that's really what's going on here from a pathologic perspective. It's this little sinus tract, little cyst that's kind of formed around this, and it's trying to transit or eliminate it. And so it formed this little cyst, and the clinician probably thought it was a cancer. It might have looked kind of blackish or brown. They might have thought it was a melanoma, for example, or a pigmented basal cell carcinoma. But anyway, it's kind of a nice teaching case because it's got that Diagnoses fungus that's not really pathogenic. And so make sure you don't overcall that. I think they would want to ask that on the exam. They might show you a splinter, and maybe might put some things in the differential diagnosis of that, like maybe argyria or a metallic foreign substance or something, and expect you to recognize it as a splinter. But I don't think they would want to. They'd probably drill down and say, true or false, this guy's got chromoblastomycosis. The answer to that obviously is false. Okay, this next one's a really interesting case too, and probably a little bit more of an educational teaching case from a standpoint of clinical dermatology, but probably not on the board examination. So you can kind of relax on this because they're not going to show you this on the board. It's way, way too difficult, but it's highly important from a clinical perspective. So here we got a shaved biopsy, neoplastic process, and the process is located in the dermis. It seems to be, we don't have a whole thing, but if you had a little compass and you could kind of draw a little, finish out the arc here, probably was about this big, overall. It's a little small papule. I don't think we're looking at the top of a giant, huge iceberg. It's probably a relatively small lesion. And so given it's probably about that deep, if we really had the entire thing, if they didn't have a punch, it's probably about as deep as it is broad. That's kind of an important finding in something like this. And notice that there's no involvement of the epidermis. There's a Grin's zone between the epidermis and this pathologic process. In low magnification, basophilic cells, kind of hard to be sure exactly what they are, but notice over here there may be a few little nests. And so at low magnification, say, well, we're not positive what it is, but maybe it's melanocytic. So we'll just see. We go to higher magnification. But at low magnification, it kind of looks benign. It seems to be relatively small. It seems to be fairly well circumscribed. We can draw a line here, a line here. It's hard to talk much about symmetry. Maybe it's a little bit asymmetrical, but not dramatically so. So we're not really too kind of concerned about it when we first look at it. We go to higher magnification, and we start, and that's, we always talk about doing everything at low. And then you want to refine the diagnosis when you go to higher magnification. It's not like we're just going to always just make a conclusion at low magnification. Sometimes we will if we see an obvious basal cell or molluscum or something like that. Sebaceous, we just may not even go to higher magnification. But in something like this, we would always go to higher magnification. And so as we do that, we notice some slightly unusual features here. We see the cells are arranged in some, not just nests, but in cords and strands. Whenever you see that, that's kind of a little bit of a red flag. Nevi don't tend to give you that pattern that much. That's often seen in things like metastatic breast cancer. It's seen in Merkel cell carcinoma. It's seen in some of the interstitial, mostly neoplastic processes like leukemia and lymphoma sometimes when they metastasize to the skin. So we see that says, that's kind of a little bit curious. We're not really going to slam dunk it into a cancer just yet when we see something like that. We've got another area over here where there's some cells that are kind of coalesced over here. And then we notice here, we'll go back to that area that I showed you a second ago, and lo and behold, there are mitotic figures in here. So whenever we see what looks like a nevoid process, and we have mitotic figures, there's 3, 4 right there together, all in a row. That's really a major red flag. That says something is going wrong with this lesion when it's got this many mitoses per unit area. And the fact that it's also not involving the epidermis, and it's got some cells in these cords and strands. There's another large atypical cell. We're going to pull back and say, even though it looks benign, kind of at low magnification, seems to be small and symmetrical in some of those features, we're going to say this very well can be a malignancy. Now, if it's melanocytic, because it's kind of poorly differentiated here, we might even say it's kind of epithelioid, and we might say, well, let's do some stains. Let's make sure it's not a pseudo-nested, pseudo-melanocytic breast cancer, for example, that spread to the skin. We see that on occasion. Pigmented metastatic breast cancer can simulate melanoma. So we've seen that, and so we might want to do some stains. But let's say we did stain and it was positive for melanocytic markers, positive for SOX10, S100 protein, maybe melanA. So it's melanocytic. Well, how do we basically reconcile that? I mean, does this look like a primary melanoma? There's nothing in the epidermis. There's a Grin zone. And so this is an example of a metastatic malignant melanoma. And metastatic melanomas, if you see patients that have METs for melanoma, they can take several different histologic patterns, different clinical patterns also. They can appear as multiple small black dots that are papular, and so that might be what something like this would appear clinically. They can appear as little amelanotic red papules on occasion, and with no melanin in them. So that's possible this one too. It doesn't really have a lot of melanin in here. They can take on features that look like blue nevi. So if you see what looks like a small puddle of darkly pigmented melanocytes in the dermis, small, not a huge broad area, small little puddle of melanocytes, and a couple of them look like maybe there's a little bit of more slight atypicality. You have to think about the possibility of blue nevus-like metastatic melanoma. Those can be extremely challenging and difficult to diagnose because they look very, very much like a blue nevus. And then you get this, dermal melanocytosis, dermal melanosis, patients that have widespread melanoma that is circulating in their bloodstream and everything. And these multiple areas of just brown, black areas in their body, their skin can turn black or brown or gray, and you biopsy those, and they just have dermal melanin. Surprisingly, a lot of those patients do better than you would think. It's generally a bad sign, but occasionally those patients will live with their melanoma for a long time when they have that pattern, surprisingly. But whenever you see something like this, where you get a melanocytic lesion, so we know now that it is melanocytic, that's almost as broad as it is deep, and it doesn't involve the epidermis. That's a very good clue that you're dealing with a metastatic malignant melanoma. So that's a situation where the pattern loses. It looks small, it looks symmetrical, it looks well circumscribed, but it's still cancer. So when you get metastatic lesions, it breaks the rule of architectural symmetry, size, circumscription, all those kind of things. So just remember that even though those are cardinal rules of benignity at low magnification, metastatic lesions can break that rule. So this was an example of a metastatic melanoma. They did a shave biopsy, which is kind of a no-no. I mean, this lesion is hard enough to diagnose as it is. When you shave it, and that's all we have to look at is something like this, it can be extremely difficult. It can result in an erroneous, false, wrong diagnosis. I suspect they probably gave us a history of melanoma and something like this, but nevertheless, it'd be better to take an incision or a punch biopsy if you're dealing with that to make sure you can kind of look at the whole thing. Okay, this is another one that you probably are not going to see on the board, and we tried to do our best to get an example to show you, and I'm not sure really makes it. But this is an example. I'm just going to tell you what this is. This is Miliaria Crystallina, supposedly. And Miliaria Crystallina is basically a situation where you get plugging of the eccrine sweat unit very, very high up in the eccrine sweat duct where it really almost empties into the epidermis. And so this little area right here, I think we may have had another section that may have showed it, might be the little small clear blister that patients get with Miliaria Crystallina clinically. There's a little dilated sweat duct here with some material in it. Normally, you don't see a sweat duct with any sweat in it that high up in the sweat duct, getting close to the surface of the skin. So this was probably just a plugged sweat duct, and maybe this is the little small Miliaria Crystallina area that you're supposed to see. So if you see miliaria, there's really three types of miliaria. There's Miliaria Crystallina, and if you're really lucky, you can actually see the sweat duct that's plugged in the little small intraepidermal slight spongiotic area, or maybe a little bit of a subcorneal blister, kind of like we're seeing here. If you see Miliaria rubra, usually you'll see the inflammation kind of occurring down around this area of the sweat duct, and you get some periacrine inflammation, usually some lymphocytes and some neutrophils, usually not too many eosinophils. And if you have Miliaria profunda, the inflammation is down in this area because it's in the lower part of the eccrine sweat unit where you get the inflammation. Miliaria profunda can look sort of similar to neutrophilic eccrine hidradenitis, where you get secretion of chemicals, chemotherapy agents and whatnot into the sweat, and then it causes a secondary inflammatory reaction. The material is usually toxic to the sweat epithelium, and then it results in a secondary chemotaxin of neutrophils and whatnot. That's when we see neutrophilic eccrine hidradenitis. So we tried, we kind of struck out, but at least we can talk about what you see in the miliaria diagnoses. We just didn't have a super good example of it. This is a good example of this disease, however, and this is probably something that you very well could see on the board examination. And they might ask you a couple of questions about it, some second-order questions about it, with a punch biopsy. And you can see it's got acanthosis at low magnification, probably taken from the trunk or the extremities. It's not a completely hairless area, but just one or two hair follicles in here and an rectopili muscle here. And we see the acanthosis, and notice at low magnification that these epidermal redi, they're expanded, and the dermal papillae look almost kind of like little balloons, if you will. They're expanded. And whenever we see something like that, we say, well, that's not normal. You know, normally the epidermal redi and the dermal papillae are really quite thin. They're not really this bulbous, and they're not really this expansile like this. So it makes us think that there's something pathologic in the papillary dermis. So that should be a clue when you see that at low magnification. There's not a whole lot of diseases that really affect the papillary dermis in that fashion. You know, porphyria, non-bullous lesion porphyria can do that sometimes. When they get the blistering, they get the festooning because you get the blood vessels that have the thick pH positive material around that. You can see it in Lichen Nitidus, where you get little collections of histiocytes in those dermal papillae that expand them, and you get kind of a ball and claw morphology. And then this disease, we look at higher magnification, and you can see it's kind of hard to appreciate, but there's amyloid right in here. This one shows it the best, and you can see that it's this very, very light, pale pink material. There's some clefts between the amyloid right here. So these are little small clefts, and notice that these epidermal redi are kind of hugging around this. So this material is deposited. You've got the sort of almost ball and claw-like morphology here of the epidermal redi and the dermal papillae here. And then you get melanophages in the papillary dermis also. Very, very common with lichen amyloid and macular amyloidosis. Now, this would probably, in this case, it's be more likely macular amyloid. And why do I say that? Well, mainly because it's got a basket weave cornified layer. When we see patients that have lichen amyloidosis, it's really basically the same process. It's macular amyloidosis that the patient is. It's obviously an itchy condition. They rub the skin, they get massive lichen simplex chronicus overlying it, and we really don't have that here. We just have a basket weave cornified layer. So this is probably macular amyloidosis, and the clinician may have had a differential diagnosis. They might have biopsied a brownish reticulated appearance, say on the back. Upper back is a common location. The pretibial area is another common location. And they might have thought it was, say, post-inflammatory pigmentary alteration, maybe burned out lichen planus because there's all these melanophages here, so it probably looked brown, like it always does. And in this case, lo and behold, it turns out to be macular amyloidosis. Now, if you look here, you can see the pathogenesis of this. These are keratinocytes that are dying slowly, and they're turning into amyloid in this area. Sometimes we'll see an early lesion of amyloid, and that's all we see. We don't see this, we just see this. And you can still make the diagnosis of evolving macular amyloid when you see this. So this is the board, the question. They'll say, you know, something along the lines of, what type of amyloid is this? Is this associated with systemic illness, like, say, someone that might have multiple myeloma? Is it something that's just kind of coincidental? Well, obviously we know that, and we know that this actually is comprised of degenerated keratin. So it's a different type of amyloid than the amyloid that comes from an immune-mediated process. This is somebody that's got myeloma, for example. The amyloid that you see in that condition doesn't look like this. The actual morphology of the amyloid looks somewhat similar to it, but that is usually a dense nodular deposition of this sort of bubblegum pink material. And for the type that's associated with immune disease, it's almost always within blood vessels. So you'll usually see some of these larger blood vessels. They'll have abundant amyloid in the wall of the blood vessels, and you'll almost always see plasma cells associated with them, at least a few plasma cells, when it's the immune-mediated form of amyloidosis in the skin. A nodular amyloidosis can appear like a large pink nodule, often submitted as rule-out basal cell carcinoma. It's often on the head and neck area, and that is not always associated with the systemic amyloid condition, but you need to work the patients up. So if they have a large plaque of nodular amyloidosis in the skin, it may just be totally coincidental, but you need to make sure they don't have a systemic amyloidosis that's causing that deposition when it's more of a nodular pattern. This pattern, you do not need to work it up. So please save the patient the money. Don't waste healthcare resources. Don't go work these patients up for amyloidosis systemically or myeloma. If they get this is just due to chronic inflammation. It's not associated with any systemic illness, and it's often seen in patients that have type 4 or 5 skin. Hispanics commonly get this, very, very common situation. And not sure exactly what the pathogenesis is. It is pruritic, and if you treat the pruritus, sometimes it'll actually kind of make it sort of resolve. Okay. Another example here of a neoplastic process, punch biopsy. So we see something at low magnification that's got spaces in it, like here. We should think right off the bat that it could well be a neoplastic process of vascular differentiation. And, vascular differentiation, there's really 2 main types of blood vessels. We've got blood vessels, and then we've got lymphatics. So you got lymph vessels and blood vessels, and basically those 2 things. And then there's a lot of different subtypes of hemangiomas. Now, that gets a little bit more in the realm of dermatopathology board questions, to some of the more subtle subtypes of the hemangiomas. I don't think they're going to show you an example of a caposiform hemangioma and expect you to diagnose that histologically, but they might expect you to understand that could be associated with the Castleback-Barrett syndrome. So they'll expect you to know the trivia about it, but I don't think they're going to expect you to diagnose the histology. And the same thing is true here. This is a subtype of an hemangioma. So you can see it's got these large blood vessels here. It's even got a valve or 2, and so you kind of might say it might even be a lymphangioma. This specific one over here has got some curious morphology to some of the endothelial cells. And notice how they kind of protrude into the lumen here. And this one we diagnosed as a so-called hobnail hemangioma because these endothelial cells look like little hobnails. Now, hobnails are nails that are used for, the carpenters use them and things like that. They kind of have they're not like nails that have a flat top to them, like used when you're like hammering wood into a house, when they use those things that they're like things that shoot the nails into them now. When they have a little sort of dome-shaped head to them, that's a hobnail, like here. So when they protrude in the lumen like that, and it's an hemangioma, then it's just known as a hobnail hemangioma. It's more of a coincidental sort of finding. It's not anything really that's that significant. If you get a lot of extravasated erythrocytes associated with them, you can get seeing the same morphology in a so-called Targetoid Hemosiderotic hemangioma. That's just another variant of an hemangioma. So not something that you really are going to likely encounter on the board examination, but just be aware of it so you know that there are all these different variants of hemangiomas, and hobnail hemangioma is one of them. There's one other situation, and this one you could possibly encounter on the board. If you get a lesion, let's say a reddish nodule, or maybe sometimes a multinodular plaque around the ear or the head and neck area, usually of a relatively young individual, and you biopsy that, it's got a very markedly thick wall blood vessels, a proliferation of multiple thick wall blood vessels with very prominent endothelial cells that protrude into the lumen, and they often have little vacuoles in the cytoplasm of those endothelial cells. That's classically seen with angiolymphoid hyperplasia with eosinophilia, and you'll often see eosinophils or even pseudolymphomatous type of inflammation in those. You don't have to see that. Sometimes the eosinophilia is circulating eosinophils, but you'll see those large, thick wall blood vessels. That's almost, you have to have that almost every time to really make that diagnosis. And the other situation where you can see that same sort of histology is in Kimura's disease. That's where you get multiple widespread lesions, not just in the head and neck area, often seen in Asian individuals. But biopsy looks pretty similar to the histology of angiolymphoid hyperplasia with eosinophilia. So that's just and that one you very well could see on the board. That's one that's a little bit more prototypical. So we'll show you an example of one of those one of these days that's as an unknown or in this session. So you'll have a chance to review that, but I would recommend knowing a little bit about that. Okay, this is an interesting lesion also. Here we've got a shave biopsy of a verrucous papular lesion that's got these little areas of acantholysis. And it's also got these marked zones of parakeratosis overlying it. And when we see something like this, we think it's probably some kind of hamartomatous process. Whenever you get these broad zones of parakeratosis with normal zones of keratosis between them, you should think about things like maybe an inflammatory Bruch's epidermal nevus, some type of epidermal nevus, some kind of a nevoid, or some kind of a hamartomatous type process when we see that. This clearly isn't psoriasis. It's got these, again, and this is not porokeratosis, but that's something else you should think about when you get these columns of parakeratosis. So this entity, and we've got it labeled here as possibly Acrokeratosis Verruciformis of Hopf, that usually doesn't give you this much acantholysis, but it can give you acantholysis in some cases. And this is probably another kind of trivial question that you might get on the board examination as maybe more of, I don't think they're going to show you this as a histology. They might show you this more as kind of a question. But basically, the idea in that condition is you get these church spire type of hyperkeratosis areas with parakeratosis overlying them usually. This isn't a classic example of it. It's kind of the closest thing that we had to it because we never see a case of this. This patient came in with multiple papules. I think they're mostly on the legs and maybe some on the trunk. They did a biopsy and it showed these kind of church spire verrucous hyperplastic areas, which is what you're supposed to see with that coupled with this parakeratosis. The acantholysis is not really a classic finding of that, so I'm not sure I would use this as a great example of it, but we just wanted to show you something that would maybe fit into that general category. There's a number of these entities that give you these little benign epidermal, mostly keratotic lesions that I would recommend learning about in general. Things like confluent reticulated papillomatosis, acanthosis nigricans, Flegel's disease, and a lot of people mispronounce that as Flegel's disease. And I remember going to a conference way back many years ago at the International Society of Dermatopathology, and Dr. Flegel was there. He actually was at the conference, and they announced him as Dr. Flegel, and he said, "Yes, that's the way you pronounce my name." So if that's the way he pronounced his own name, that's the way we should pronounce it. We shouldn't call it Flegel's. It's really Flegel's disease. And that's another condition where you get these, it's a keratotic epidermal mostly process. So sometimes the pathology is mostly in the epidermis. So make sure that you kind of know some of the diseases that give you that. Golly disease, acrodermatitis, Dohe, there's a bunch of those. So just make sure you kind of understand some of those. You may encounter some of those on the board examination. Okay, here we've got a biopsy taken, and usually when we get a biopsy of alopecia, we get both a horizontal and a vertical. So they're probably not going to show you this with a only vertical or horizontal section like this. They're going to show you both the horizontal and the vertical section if they're going to show it to you. But here we've got an alopecia. And the nice thing about these sections, so just to kind of educate you a little bit about that. One of the reasons this actually was developed years ago by Dr. Headington, who was a dermatopathologist in Michigan that was interested in hair and also at nexal neoplasms. He said, well, you know, if you just look at a regular punch biopsy and you just cut it in the typical fashion, you're only looking at about 8 to 10 follicles. If you cut it in a horizontal fashion, up, say, near the infundibulum and then down maybe near the lower part of the follicle, you can see about 20 to 30. So you can really assess a lot more of the hair follicles. And so when you're looking at something, this would be kind of near the, just beneath the level of the infundibulum and the isthmus. So you're seeing the sebaceous lobules, so you can imagine. So this is something like a CAT scan, if you will, as opposed to just a regular plain film, if you will. Or maybe this is like confluent microscopy rather than looking at regular H&E type sections that we, cut perpendicular to the tissue. So here you're seeing the multiple sebaceous lobules with an increase in the number of these small miniaturized follicles with virtually no inflammation. And so if we were to look over here, this is down in the subcutaneous fat. And so normally we should see about 20. Well, we see about half that number. So we know this person's got an alopecia. We don't see any perifollicular fibrosis. We don't see any significant inflammation here. So this is a classic example of androgenetic alopecia. So if you look at a horizontal, routine section of alopecia taken from, say, somebody that's got androgenetic alopecia, it really looks almost like a biopsy from their face. The follicles are smaller. They're not really rooted in subcutaneous fat. You only have about maybe 4 or 5 or 3 of them as opposed to 10, so about 50% or less of the number that you should have there. So it looks almost like a biopsy of somebody's face with lots of sebaceous lobules and smaller follicles. So that's a way you can tell androgenetic alopecia almost instantaneously at low magnification when you see that pattern. So this is what happens when you see it on the transverse section. We're looking at it cut in the opposite way that we usually look at it. And you see all these multiple large sebaceous lobules with these small follicles, and then the absence of any other pathologic change. So we don't see 3 or 4 follicles lumped together with perifollicular fibrosis like we might see, for example, in a late-stage lesion of lichen planus. We don't see any fibrosis surrounding these individual follicles in a circumferential fashion like we might see, say, for example, with traction alopecia. We don't see any trichomalacia like we would see with trichotillomania. So we don't see any of those features. We see just mainly sebaceous proliferation and a decrease in the number of the large anagen follicles like we should see. So that's classic for androgenetic alopecia. No peribulbar inflammation that we'd see, for example, in alopecia areata. So alopecia is really not super difficult if you have good criteria and have a systematic approach to diagnosing it. So we always ask ourselves, whether we think it's an inflammatory or a non-inflammatory alopecia, whether we think it's permanent scarring alopecia or permanent non-scarring alopecia. For example, alopecia areata, I think we can probably change that today from permanent non-scarring alopecia to non-permanent alopecia, because now with all the JAK inhibitors and whatnot, we can reverse a lot of that. But in the old days, people with alopecia universalis would never grow their hair back, no matter what you did, virtually impossible to grow it back. But now we have good drugs that can do that. But nevertheless, you look at those kind of patterns, look at the type of scar. Is it involving only the follicle? Like, is it a rifle shot into the follicle, or is it involving diffusely throughout the skin? Like you say, for example, in folliculitis decalvans, it just sort of marches through the entire skin. It doesn't just respect the follicles itself, whereas lichen planus targets only the follicles. Discoid lupus erythematosus generally gets mostly the follicles. We can get inflammation between the follicles. And then the non-inflammatory alopecias, things like, traction alopecias, they're scarring just around the follicles there. So there's a nice way to work through alopecias. And if it's systematic and you go through that, just like with paniculitis, you can usually make a correct diagnosis. From your standpoint of the board examination, they're going to give you things that are pretty straightforward and not things that are going to be esoteric and almost impossible to diagnose. Okay, here we've got a shave biopsy, and unfortunately, we didn't get a really nice punch biopsy in this example. And we like to get punches whenever we see inflammatory skin diseases. So they're not going to show you this on the board. They're going to show you something that's pretty classic. But the nice thing about this is it shows all the diagnostic features that we're supposed to see in this condition. So at shave biopsy, you might think it's a seborrheic keratosis. And then you look down on the path rec slip and it says it's a widespread erythematous eruption involving the palms and soles. Well, it's obviously not a seborrheic keratosis, it's something else. And when they give you that type of clinical description, then you start looking to see if it's some kind of inflammatory process that gives you a widespread erythematous eruption like psoriasis, atopic dermatitis, widespread allergic contact dermatitis, maybe mycosis fungoides, all the various things we think of in the papillosquamous disease category. So if you look at the epidermis here, it's not normal. It's acanthotic, but notice that it doesn't have the nice thin epidermal rete that go fairly deep into the papillary dermis that we would see in a patient that has psoriasis. It's got these blunted, sort of fat epidermal rete that have sort of coalesced at the dermal junction. That's a classic finding for this condition. So that's the first thing that I want you to notice. The second thing to notice is the cornified layer. It's not normal. You've got a thick cornified layer here that's got some parakeratosis in it, and it's got some basically cornified layer overlying that. It's got a little bit of hypergranulosis. It doesn't have too much inflammation. So we know that it's mostly a papillosquamous disorder. And then let's look at the cornified layer, and you can see that it's got parakeratosis, retention of nuclei here. And if we take our arrow, we start off at the granular cell layer and go north, we see that it's got orthokeratosis. It's kind of laminated here, parakeratosis, ortho, and then para and ortho, and then some basque weave at the top. So it's got this sort of checkerboard-like change. And then if we kind of follow this little strand across, we see nuclei, nuclei, no nuclei, and maybe some nucleus over here, nuclei here. So it's parakeratosis alternating both horizontally as well as vertically. That is a classic pattern for Pityriasis rubra pilaris. And if you couple that with these rete over here, you can make the diagnosis on this even without seeing some of the other classic features like the follicular plugging, and even if we have a shave biopsy and whatnot, we would call this PRP. So this is a nice example of unfortunately, a shave biopsy of PRP. And this has one other finding that's kind of interesting. It's got this acantholysis here, okay? Now that's not a criterion for the diagnosis of PRP. You don't have to have it. But if it's present, it's a helpful clue, because you do not usually see this in psoriasis. You don't see it in atopic dermatitis. You don't see it in mycosis fungoides. So if we see this in the setting of a widespread psoriasiform dermatitis that's got these other changes that I mentioned to you, that's like, say, well, boy, that really adds fuel to the fire, if you will, that it's really PRP, more likely to be PRP. And there's an old saying that you don't want to be the first dermatopathologist or clinician, for that matter, to see a patient with PRP, because you're going to miss the diagnosis, because it often takes a little while for it to sort of declare itself. But if you see these features and you're the first dermatopathologist to see it, you can be a superstar and you can make the diagnosis because you've applied these criteria that I just showed to you, and that you can make the diagnosis even if it's not an optimal biopsy like we don't have here. So those are the classic things you look for with PRP: the fat, blunted, acanthotic epidermal rete that is not as prominent as we see in psoriasis. You don't get the loss of the granular cell layer the way you do in psoriasis. You don't get the neutrophils in the cornified layer like you do in psoriasis. Rarely you can if in an atypical PRP, but if you see this pattern, this is kind of what you're getting on the board examination. You're not getting any of the atypical PRPs or anything weird. You're going to probably get a nice, deep, broad punch biopsy that shows those various features. And if you see acantholysis, that's going to be a helpful clue, and just remember that you can see that. Okay, here we have a punch biopsy, and it's got this interesting finding here. If you look at the basal cell layer, it's got this curious plate-like proliferation of these unusual follicular structures here. Okay, it's actually, this was probably an excisional biopsy. I don't really think it was a punch biopsy. You got this green ink at the bottom. And I don't know why this was an excisional biopsy. It's possible that the patient may have had an erroneous diagnosis of a basal cell or something on a shave, and they went back and incised it, and we got the real diagnosis here. So this is a neoplasm. And the differentiation, whenever we look at a neoplasm, is it epithelial or is it non-epithelial? Well, this is epithelial neoplasm. And you can see that it's basically got follicular epithelial differentiation. And it's not like, so we have really four parts of a hair follicle. We've got the inferior portion of the follicle where you have the hair bulb, like this little tiny vellus follicle here. We've got the infundibulum of the follicle, like we've got here. Then we've got the isthmus of the follicle, which lives between the infundibulum and the inferior portion, which would be kind of around here. And then we've got the area where this little neoplasm developed from, the so-called mantle zone of the follicle. And that's a stem cell area that lives in this zone between the infundibulum and the inferior portion of the follicle. These cells right here. Those cells are pluripotential, and they can do a lot of different things. They can form sebaceous glands, they can form apocrine glands, they can form, when the follicle cycles, they can reform the new inferior portion of the follicle that comes back after the follicle goes through catagen and telogen. They can sometimes form hamartomas. And in this case, you can see it form this little curious hamartomatous process here. These little strands of these cells here that have got these little bizarre single cells that are the primitive germinative follicle cells, sort of analogous to these cells right here. Here's a little tiny primitive infundibulum, if you will. And notice that this structure is kind of oriented in a horizontal fashion over a relatively broad front, as you see here. So this is a nice example of what we call a tumor of the follicular infundibulum. Now, it's probably not the world's best name. And, you know, today, if we were naming this, we probably would call it maybe something like a mantelloma, if you will. In fact, some people have written articles where they call these things mantellomas. And they're basically, it's like a little neoplasm of the mantle zone of the follicle. And it's producing this little primitive follicular structure here. And the key to it is that it's oriented in a kind of horizontal fashion over a relatively broad front. That's the clue to this. It's always in this plate-like fashion like you see here. So this is classic for this. It's a little bit esoteric, but they could ask you this on the board examination. It's fair game. You should know what it looks like. So you should know what all these various adnexal tumors look like. And I would probably say if they're going to ask you one of these kind of slightly unusual follicular tumors, like not a classic trichoepithelioma or a desmoplastic trichoepithelioma, they would probably ask you more like a trichofolliculoma. They might ask you trichofolliculum, which is not that. That's a cyst with little radiating inferior portions of the follicle surrounding it. They might ask you something like a perifollicular fibroma or a trichodiscoma that can be associated with Birt-Hogg-Dubé disease because that's associated with the syndrome. And so they might show you that and say, what other workup should you do on this patient? And then the question might be, do a chest x-ray to look and see if they have pneumothorax from blebs that form in their lungs. They might say, do a urinalysis to see if they've got any urine that's got blood in it that's associated with underlying kidney tumor that might be associated with it. They might say, do an ultrasound of their kidney because they can get kidney tumors associated with Birt-Hogg-Dubé. So make sure you know those various syndromes and know the diseases and other findings that you see in those syndromes, because they like to ask those, and you should know those as a dermatologist, what things that you need to look for if somebody gets one of these tumors. But the thing that this one is not associated with anything. So if you get just one of these tumor follicular infundibulum like this, it is not associated with any other underlying condition. So it's nothing really to worry about. Okay. Let's look at this one here. So we've got another excisional biopsy, and it's fairly broad lesion. And so it's pretty deep too. So we got and we look at low magnification, say, well, if it's neoplastic, does it look epithelial or non-epithelial? And I don't see anything here that looks like an epithelium. So when we see a non-epithelial lesion in dermatopathology, there's really three main things we think about. Now you can get a lot of other non-epithelial lesions in, dermatopathology and anatomic pathology, but for your purposes, the three main ones that we think about are neural, fibrohistiocytic, and muscle. So those are the three main ones. So you can, if you want to get into the weeds and get into, some other bizarre, non-epithelial neoplasms and things like that, like Ewing sarcoma and all those sort of rhabdomyosarcomas and those sort of things, go right ahead. But for the main purpose of the board examination and for the things you really need to know, those are the three main ones that we really want you to focus on. So we're going to ask ourselves here, which of those three is it going to be? We can also look at low power, say, is this thing benign or malignant? And, it's pretty big. It's not super asymmetrical. It's pretty deep. We don't know how deep it goes. When it's deep and it extends into the fat like this, we can't really draw a line around the bottom of it. That's a little bit of a red flag. That sort of says, well, maybe it's malignant. We're not sure. It certainly doesn't look anaplastic. So if it's malignant, it's probably not going to be super aggressive, like maybe something like a spindle cell malignant melanoma or something like that, or poorly differentiated squamous cell carcinoma and angiosarcoma. So we're going to higher magnification to see if we can figure out what kind of differentiation it's exhibiting. And so we know that when we're looking at the three main types of differentiation here, if we're looking at the nuclei of the three cells, we're looking for, if it's neural, it's usually kind of a lazy S, a delicate spindle cell type of cell that looks kind of like a lazy S, kind of swimming slowly in a soft way through the slightly fibromucinous stroma most of the time. That's what we look for when we see neural most of the time. If it's fibrohistiocytic, the cells are usually either kind of angulated. They're not usually like these delicate cells slowly spindling. If they're anything, they look kind of irregular and jagged, and they form these zigzag kind of morphology. And if they're muscle, they tend to be kind of blunt-ended, like cigars, like we see here. If you look at the cytoplasm, neural, the cytoplasm is usually, sometimes it's kind of delicate and it may have a slightly mucinous character to it. If it's muscle, it generally tends to be pinker, like we see here. And if it's fibrohistiocytic, it may have very little cytoplasm, or it can be somewhat kind of clear sometimes, like for a histiocyte, where you can get kind of slightly clearish cytoplasm. So you kind of use those features to help you. If you're not sure, then obviously we can resort to immunoperoxidase stains that can help between the three. But here we see that we've got this blunt-ended characteristic of these nuclei, and we've also got this kind of pink coloration to the cytoplasm here. So we would probably favor a muscle tumor here. Another thing we often see in muscle lesions are these periapical vacuoles, like you see right here. They're often at the end of the nuclei. You'll see these little vacuoles associated with them. That's also really characteristic of muscle. So this is a nice example of a smooth muscle neoplasm. Now, if we're looking at muscle differentiation, we use the criteria that we do for benign and malignant at low magnification. So this thing is pretty big. It's a little bit asymmetrical. So you say, well, it may be malignant. And then you look at the cytology. You look to see if there are mitotic figures, if there's pleomorphism of the individual cells. And we do have some large, irregular muscle cells here. We're going to look through here, and you're going to probably see some mitotic figures. And that's actually, there's one right there. So if you start seeing a fair number of mitoses, like maybe more than a couple per millimeter squared in some areas, then you start saying, well, if it's large, it's asymmetrical, well, then it's going to be classified as a leiomyosarcoma. If it's got just a few of those atypical features, and it's not really, frankly, atypical with a lot of mitoses, then some people call it an atypical leiomyoma. So if you're look at the way the soft tissue pathologists grade these things, they call them leiomyomas, atypical leiomyomas, and then leiomyosarcoma. This one we called a leiomyosarcoma because it was large, it was asymmetrical, it was deep, and it had a lot of mitotic figures and other features. But the good news about a leiomyosarcoma that occurs in the skin is that it's associated with an extremely good prognosis. So it behaves really more like a dermatofibrosarcoma protuberans. And they don't recur as commonly as DFSPs do either. These are usually fairly easy to excise with maybe a 1 centimeter margin. And once you get them out, they very, very rarely metastasize. as opposed to a leiomyosarcoma that occurs inside say, the pleural cavity, for example. Those often do metastasize. These often do not metastasize. So if your patient has one of these, you can reassure them that it's got a pretty good prognosis. Just get it excised, and they're going to have a low chance of this really spreading. It's not a zero chance, but it's a much lower chance than a leiomyosarcoma that occurs in other locations. The only other teaching point about smooth muscle neoplasms in the skin, obviously they're one of the painful tumors of the skin, so make sure you know that. And it can be associated with Reed syndrome, which can also be associated with other conditions with microsatellite instability, with GI malignancy. So once again, make sure you know about Reed's syndrome associated with smooth muscle neoplasms. Okay, this one you're going to get on the board for sure. So they'll show you this somewhere on the board examination. This is an excisional biopsy, beautiful example of this from the scalp. And so you see over here, you have all these very deeply rooted terminal follicles in the subcutaneous fat. And notice that there's hair here, and there's no hair centrally. So clinically, this would have appeared as an area of alopecia. So you see these patients come in, they've got this area where there's no hair, and you say, well, how come there's just a localized area of alopecia? Could it be something like alopecia areata? Could it be aplasia cutis congenita? Could it be some kind of neoplasm, if you will, that's causing it? It could be some sort of hamartoma. And you can see at low magnification, there are a lot of sebaceous lobules here. Very few sebaceous lobules here. The sebaceous lobules that are here are present associated with the follicles. It's a really nice teaching example of this. I'm not sure I've really ever seen one where you really can see the contrast here. But notice these sebaceous lobules are hugging the infundibulum of these follicles here, right where they normally belong. And then you get to this zone, and notice where these sebaceous lobules are. They're not associated with any hair follicle, and they're touching the epidermis. They're way the heck up here in the epidermis. And that's not where they belong. They should be associated with hair follicles. Here's a follicle that's bizarre. It's only got an infundibulum. It has no inferior portion. Here you've got these little bizarre matrical areas here that look like they're probably little mantelomas, again, like the tumor follicular infundibulum. They're little hamartomatous proliferations here. Then you've got other areas where you've got sweat glands sitting in here. Shouldn't really be there either. So this is a hamartoma. And I'm sure you know what the answer is. This is a Nevus sebaceus of Jadassohn. So here's where there was hair. Here, there's no hair because the hair has been replaced by these hamartomatous bizarre sebaceous proliferations and these bizarre follicular structures that have formed. And notice also there's this verrucous epithelial hyperplasia. Sometimes you'll get what looks almost like warts, like triclinial verrucae in these lesions. Then there are little verrucous areas there, but these are not really HPV induced. Sometimes you can get syringocystinomal papilliferum. So here we've got apocrine glands and eccrine glands. Those really shouldn't be sitting there in the middle of a non-hair bearing scalp. You know, you got all these sebaceous lobules. So this is also part of the hamartoma. We sometimes get lesions that look like basal cell carcinomas. They're not really basal cell carcinomas. They're really basaloid follicular proliferations that can simulate and look like basal cell carcinomas. So this is a beautiful example of a nevus sebaceous, and you can just see the difference between the normal architecture of the sebaceous glands in the follicle here and the completely abnormal architecture. And they excised this whole thing. So they basically took it out, sewed it up. There's no more area where there's no hair, and patient's scalp now looks perfectly normal. But it's a beautiful example of a nevus sebaceous of Jadassohn, and a nice contrast between the normal hair-bearing area and then the abnormal hamartomatous area. So you're going to get some questions about this absolutely positively for sure on the board examination. So they may ask you what type of neoplasms or hamartomas are associated with this. And then one of the most common, probably the most common of the basaloid follicular hamartomas, but another very common one is that syringocystinomal papilliferum, very, very common associated with it. Last one we'll do real quick, shave biopsy from A non-hair-bearing area, or if there is hair-bearing area, it's very limited. I don't see any hair follicles here at all, so it's probably mucous membrane. And it shows a marked verrucous epidermal hyperplasia. They may have thought this was a cancer, so it comes from somebody's lip. I'll just tell you that, just as a general information. Notice it's got all this acanthosis. It's markedly verrucous, and it's got this area over here where there's a lot of inflammation within the epithelium. There are neutrophils in the upper part of the epithelium, this abnormal cornified material, and this markedly acanthotic epidermis. Now, they thought this was cancer. It's on somebody's lip. Older person, the lip, it's crusted, verrucous area. Obviously, you want to rule out a malignancy. So they took a shaved biopsy of it, and you look at it, and you say, well, yeah, there's all this acanthosis, and, you know, there's maybe a little bit of keratinocytic atypia. Boy, there's a mitotic figure. So, gosh, does the guy have cancer here, you know, when you see this? But you always look when you get something from the lip to see if there's any inflammation up here that could be explaining the process. And here we've got all these neutrophils, and hopefully with all these conferences we've had up to this point, whenever we say there are neutrophils within the upper part of the epidermis or in the cornified layer, that's one clue that you may be dealing with an infection, especially a fungal infection. And when it's on the lip, you should always be thinking about candidiasis. And so you look carefully up in this area, and there are areas of candidal organisms up here in this area of pustule formation in the epithelium. So this is an example of verrucous candidiasis inducing, here's some candidal organisms right here that are drilling down into the epithelium, almost like an oil well. That's how the candida grow into the epithelium, as opposed to dermatophyte, which tends to grow more horizontally. Candida grows down into the epithelium. And you don't have to have a lot of organisms. You have really few organisms and cause a lot of inflammation. And so whenever you see something like that, do not jump to the diagnosis of cancer. What we do when we see this, we sign this out as verrucous candidiasis. We recommend treating the candidiasis first, get rid of that, and then seeing what happens. And in many cases, this stuff just vanishes. It's mostly pseudocarcinomatous hyperplasia. You can get an occasional mitotic figure in pseudocarcinomatous hyperplasia. It's pretty frank cytologic atypia in pseudocarcinomatous hyperplasia. That doesn't mean that they've got cancer. So treat the candida, see what happens, and then if they still have something there afterwards, then maybe take a biopsy to make sure they didn't have maybe a actinic chylitis or possibly early evolving squamous cell carcinoma that was with superimposed candida, which can happen. But we don't really see anything here that's frankly malignant, and you would want to treat the candida first and then see what happens and then reevaluate the patient. A lot of times stuff just goes away and they've got normal epithelium after the fact. So beware of pseudocarcinomatous hyperplasia, looking like cancer, getting overcalled as cancer. And, you know, it's a pretty aggressive thing if you call a cancer of somebody's lip that's inflammatory. You know, that's usually a pretty aggressive surgery. They'll do like a wedge excision of somebody's lip. So you don't really want to have that happen in a situation like this. So this one's not as hard because this really doesn't look all that atypical, but sometimes you'll see these that really look very atypical and really can simulate a squamous cell carcinoma, but it's only candidiasis. Okay, well, that's it for today. You can go to our website here and look at these and pull them back up at any time. So if you want to review this session, you're welcome to do that. So hope this was educational for you this morning, and we will see you next time. Thanks for attending.